Hello students, we will discuss condition which is very interesting. Look at this, what this condition is. See here, over the wrist, there is a proliferative lesion with slough, of course, raised and everted edge with some changes in the skin surrounding area also. So very typical lesion. What is this? So naturally there are only two possibilities you have to think of, mainly neoplastic condition and of course inflammatory uncommonly. Neoplastic condition, mostly it is malignant. You have to assess based on the history, duration, pain present or not, rapidly growing or not, and when history of trauma is there or not, and how it is progress also important. Based on that, and also examination, you can see raised and everted edge. It's very typical of the neoplastic proliferation edge. You can see that will not happen in the inflammatory condition unless pseudo tumors in certain other areas, not in this area. So that is a mostly malignant skin tumor. So what are the differential diagnosis? SCC of the skin possible. Amelanotic SCC is nothing but squamous cell carcinoma, epithelium of the skin. Amelanotic melanoma can be like this. It's if it's very aggressive, short duration one. Soft tissue sarcoma also. It's unlikely to be inflammatory pathology because in this patient, history is a very short duration, not much painful. And other thing is aggressive skin adnexal tumor. It's another possibility you have to think of as a differential diagnosis. Skin adnexal tumor. Skin adnexal, you know that, sweat gland, sebaceous gland and hair follicles. So tumors arising from these structures are called as skin adnexal tumor. There is also other possibilities. So how to evaluate? Already told, proper history, fixed CT, nodal exam, systemic exam, everything. Axillary lymph nodes have to be examined properly. All of you know how to examine that. MRI of the part, wedge biopsy, gives histological diagnosis. Markers may have to do. FNAs of the axillary lymph node, PET CT or PET CT to find out the systemic, especially if you think sarcoma, melanoma, PET CT. If it is squamous cell carcinoma, depending on the situation, if it is very aggressive, then only we will do it. But if it is sarcoma, melanoma, PET CT is better. And management is wide local excision with the reconstruction and axillary node dissection if it is squamous cell carcinoma or something, and adjuvant therapy later. Adjuvant therapy is chemotherapy, radiotherapy, depending on the type, markers, other situation, grading, everything comes into the picture when you decide the adjuvant therapy. Now, local therapy is wide local excision, and olden days amputations were the practice above the level. But currently, give neoadjuvant therapy, maybe chemotherapy, depending on the biopsy report, then shrink the tumor, then wide localization you do and reconstruct. So, limb saving, function saving surgeries are becoming more and more popular, unlike in olden days where we used to do regularly amputation. Amputation done only in selected patient where everything every adjuvant therapy, neoadjuvant therapy fails and disease is adherent. There is no way you can able to salvage the limb as such. Where you want to have a proper oncological clearance, which is the important target in all onco surgeries or any malignant condition when you operate. So that is the management aspect. Now limb salvage becomes priority currently in the upper limb and lower limb, most of the malignancies, unless it is very advanced. So students, see, you can go through my clinical method surgery to how to examine skin ulcer, skin malignancies, skin swellings and other things with a proper video examination lectures, with the proper video examinations, and my manual detail about skin tumors and operative surgery to reconstruction procedures, and my DigiNow lectures through JP gives a detailed idea about everything for UGs with their CME syllabus and FIGs basic thing as such. So students, I hope you understood the skin condition, neoplastic condition very well. Thank you very much.